Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's slides using the Files pod located directly below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hunt. Please go ahead.
Thank you so much, Stephanie. Hi, everybody. Welcome to the October 2020 AHA Team Training Monthly Webinar. This one is on obstetrics team-based approaches to improve value. And we are very happy to be joined by some great speakers today, and also very happy that this webinar is sponsored by our friends at Enjoy Health Education. This is Chris Hunt, Senior Director with the American Hospital Association Center for Health Innovation. So thank you all for joining us today. Just some rules of engagement. The audio for the webinar can be accessed in two different ways. You can either listen through your phone, and if you do that, mute your computer speakers so you don't get a weird feedback, or you can listen through your computer. All hyperlinks on the screen are active if you click them, and we'll open another window. And we'll do Q&A at the end of the presentation. So we encourage you to use the chat box you see on the right-hand side to write in any questions you might have. We'll answer the technical ones as we go, but if there's any content-based questions, we'll collect them, hopefully put them in an understandable order to have a nice narrative discussion at the end, and we'll do a Q&A with all the speakers if we have a chance to. Continuing education credit, you can get 1 CE hour for this webinar through our partners at Duke University. Instructions are on the screen right now about how to do that. There is also instructions in the file pod, which you see on your screen right now that says instructions for webinar CE credit. You could download that and learn all about how you get CE credit from our friends at Duke. Some upcoming team training events. Our November webinar is called Same Storm, Different Boat, using TeamSTEPPS strategies to navigate the uncharted waters of virtual learning. So very, very pertinent right now, I think, as we're all thinking about virtual learning going forward. Also, we'd love to have you on our online community platform, Mighty Network. It keeps growing. There keeps getting to be more content, so please join us there and sign up. And very soon we'll be announcing more virtual workshops and courses. Our first course right now is going on. It's a 7-week course, and I think it's going really well so far. So we'd love to have you on a course in the future. Check out the website for more options on that. All right, without any further ado, I'd like to introduce Debbie Young, who's Customer Relations Manager with our partners, our friends at Enjoy Health, who are sponsoring this today. So, Debbie, take it away.
Thanks, Chris. You know, for 30 years, I've been educating parents during the childbearing years, teaching classes like understanding birth, understanding breastfeeding, and understanding your newborn. I found that working at various hospitals has really helped me understand both the patients and the healthcare professionals. And for the last 7 years, I've been working with Enjoy Health Education to make sure that other educators and health professionals have access to excellent teaching materials. Over that time, I've come to realize that educated parents can help avoid some negative health events because educated patients become partners in their own healthcare. Healthcare providers can increase the chance of perinatal education by including conversations about the importance of education during prenatal visits. And if appropriate, you could always provide materials right from your office, or you can refer them to local classes, either classroom or right now virtually taught because of COVID, right? Your care begins education that's going to span across all touch points for these patients. And that education is going to continue bridging the transition of bringing the baby home from the hospital with postpartum discharge teaching that's going to include materials with important information to help parents understand when they need to seek help for any postpartum complications or emergencies for themselves or their babies. Enjoy Health Education has materials to meet all of those needs. Our understanding curriculum includes books and web apps and online classes for additional learning from pregnancy to parenting. Care coordination starts with educated patients. We hope you have a wonderful webinar today. Reach out if we can assist you. And now I'm going to go ahead and hand it off to Aisha.
Thank you, Debbie, and thank you to the AHA team training team for hosting this webinar today. I wanted to take a few minutes to talk about the Value Initiative. In December 2017, the Value Initiative has started and engaged over 5,700 hospital leaders, providers, and community health stakeholders to really have conversations around affordability and value. The Value Initiative now provides thought leadership, resources, and tools to the field around issues of obtaining affordable care and achieving value. Here is the value equation. We want to highlight that for generating value, hospitals and health systems are working towards improving outcomes, experience, and reducing costs. Over the course of our work, we've highlighted nearly 50 value-generating strategies and are working to highlight more tech-like, simple, human, and scalable value-based approaches, which includes team-based approaches for obstetrics. So how does this work connect with the obstetrics work? Every year, 50,000 women suffer a severe maternal complication, and 700 women die from giving birth. And more than half of those deaths can be preventable. Research has shown that 40% of women also have reported communication problems during their prenatal care, leading to adverse events. Delays in effective communication can impact a patient's outcomes, their experience, and increase healthcare costs, all contributing to higher costs for the patient and for the healthcare system. Therefore, effective and sustainable team-based approaches are essential in improving obstetrics care and achieving value. So as part of our the Value Initiative From Paper to Action project, the AHA team training team and the Value Initiative team are joining forces to develop a specific team training model for obstetrics. We really hope to increase situational awareness and improve detection and coordination of critical obstetrics emergencies through this work. And with that, I wanted to leave you with a new resource that we just put out a couple weeks ago. It's called the Team-Based Care Creates Value Issue Brief. You can click on the link to access it or visit our website for more resources. And I want to take a few minutes to introduce our speakers today. We have a great panel. We have Elissa Concini from Geisinger. She is the Women's Health Quality and Safety RN. We have Rachel Cunniffe, who is a nursing professional development specialist at Geisinger as well. And then we have Dr. Diana Conterars, Chairman of the Department of Obstetrics, Gynecology, and Women's Health at Atlantic Health System. Elissa, take it away.
Thank you. So, as Aisha said, my name is Elissa Concini. I work for Geisinger. I've worked here as a nurse for 10 years. My background is labor and delivery, but in my course of 10 years, I've been the staff development nurse for our perinatal high-risk labor and delivery unit, and then additionally, now I serve as a quality and safety nurse. I'm a newly certified obstetric and neonatal quality and safety nurse, which makes me so excited to be able to utilize a lot of the skills that we'll talk about today in really assisting teams to work together for prevention of errors, enhancing communication, so many wonderful things. So without further ado, we'll get started. You'll see here today's objectives: understanding the use of TeamSTEPPS in obstetric care and its impact. We'll identify tools and metrics to track quality of care for obstetric care and discuss ways that team-based care brings value to the patient, provider, and hospital or health system. So I think it's important for us to talk a little bit about what Geisinger is and how TeamSTEPPS came to Geisinger. So in 2017-2018, there were Master Trainers courses that occurred throughout our organization because we received a grant. So University of Washington came and taught us TeamSTEPPS. So we had a wonderful experience with that team, looking at a room of Master Trainers, multiple rooms as it had expanded. When we looked at where we would bring TeamSTEPPS in Geisinger, there were areas that the Geisinger really focused on, obstetrics being one of them, pediatrics, and also the ORs as well, thinking about what areas sort of work together. So if you can think about that as a perinatal unit, we interface with those areas frequently. Those were really our focus areas at first. GWV, one of our more urban hospitals, tertiary care centers, they really took the lead, and they were the first hospital to implement TeamSTEPPS, and we'll talk a little bit more about that. Rachel will give you a great overview of the work at GWV, followed by our other hospitals. GMC is our tertiary care center in a very rural area, and we've even recently expanded to our brand new labor and delivery unit at GCMC in the Scranton area of Pennsylvania. So you could see it took a couple years for us to get really implemented throughout our entire system. So these are our hospitals with labor and delivery units and obstetric units, which we will focus on today. So what happened when we all became Master Trainers, and how did we really get from education to implementation of TeamSTEPPS? So after our Master Trainers courses, each unit developed a team, a change team. It was multidisciplinary. We involved anesthesia, NICU, pediatrics, OB, providers, nurses, everybody we could think of in these change teams. And through the change teams meetings, the tools were chosen. And then, how do we kind of define what tools we wanted to start with? I think each hospital was a little bit different in that. Ultimately, all the tools that you see here are utilized or will soon be utilized throughout our whole system. So the two common themes that we learned when we implemented this across our 6 sites was that briefs and huddles and debriefs, those 3 tools were really integral in how we create opportunities for communication as an interdisciplinary team. So we'll focus a little bit about some of the details of those. When we look at I Pass the Baton, just as a handoff tool, CUS, really expressing our safety concerns, and general communication using an SBAR format. Those are things that really just come naturally to us now, but certainly were tools that we did roll out in a formal way. And when we started to roll out our tools, that really came with education to the staff members and the bedside clinicians that are going to be working together as teams. Each hospital did this a little bit differently depending on how their teams worked. Some sites used blocks of time, about 1 to 2 hours in length. Other sites needed to kind of pare it back and do multiple sessions. So when we did that education, not only did we focus on the tools, but really what was the root of TeamSTEPPS, and that's how I personally refer to it as, what is the root of this? What is the point of this? And if you think about teams and high-functioning teams, what makes a high-functioning team? And I think Dr. Conterars later will be looking at our TeamSTEPPS, the triangle, the picture there, so we'll talk a little bit about that high-functioning team perspective as we keep moving forward. But that's what we think about when we provide the education, not only the tools that we're using and how to use them and when to use them, but what's the reasoning behind a debrief ultimately, talking to one another and bringing up concerns in a non-punitive way in a group discussion with good two-way communication and celebrating wins. So this year really brought us into a whole different perspective with what TeamSTEPPS can do for us. And so, of course, we have to talk about COVID-19 and how we've utilized TeamSTEPPS in obstetrics in this, unprecedented scenario. So think about initially, for us back in March when we really started as an organization to rapidly explore best practices related to what we need to do with SARS-CoV-2, how we need to screen on our labor and deliveries, and the fear that lived in every single person, regardless of their ability to adapt to change. Every single person had fear. So this was so new and so different. We saw varying levels of comfort and understanding and, willingness to adapt. I think the word nimble came up countless times. We had rapid change daily, multiple times a day, hourly. I mean, we are all probably on the phone relating to this now. So how did we help with that? How did TeamSTEPPS help with this? And one of the things that we did with Women's Health, with our provider team, every morning there was a huddle. I'm happy to say that the huddle frequency has decreased significantly for good reasons now. But initially, it was, we need a huddle on this, and every single person knew what that meant. The information was conveyed. It was concise. Really great forum for providers across our system to get the latest updates and how they impact our patients. We had a perinatal huddle, and this was involving across our whole system, all of our leaders in OB, nursing, providers, anesthesia, pediatrics, NICU, everyone that touches a pregnant woman or a newborn baby. And that huddle, again, everyone knew what that meant. When we called that huddle, I feel like we had almost 100%, call attendance during those times when we were using the tools we've already utilized in other ways to really help us with COVID-19 and its impact. And no surprise, I think we also utilize our huddles when we do have patients who are positive, COVID-19 positive, who are here with us to kind of gather ourselves prior to admission if we're able to plan, but then upon admission if it was an unknown and now new case for us. So those huddles occur throughout their care involving different team members, but it was really great to not have to explain the process of all of that. We said huddle and everybody huddled. It was a wonderful experience. So with any new processes or culture changes that we try to implement, there are certainly challenges, and we have continual challenges, but we've also had a lot of great successes in this. So when we think about first implementing TeamSTEPPS, over 2 years ago now, and what challenges we were faced with then versus what we're looking at now, things are different, but there are still some similarities. There's always continual change. There's so much going on in healthcare. It is hard to keep everyone focused on TeamSTEPPS. So we learned that there was all of these new staff members that never had the training, and now we're playing catch up with that, especially because in-person sessions were really significantly paused. And now we're getting innovative with how we're doing our training. Firefighting is still happening. So these are situations that happen every single day that you kind of have to turn your attention to very quickly, pivot in the moment, and work through that. So then, some of those kind of tasks that you want to get to, you don't get to. We learned through actually a survey of our hospital system that we actually can improve our handoff process and our real-time feedback processes. So we're still having some challenges with those. Interdisciplinary team communication, that has been a variable challenge with us. There are some areas, and Rachel will talk about GWV, Geisinger, Wyoming Valley, that just do an excellent job with this, that really just support every other hospital in our system with how to do this well. And then there are some sites that are still struggling, and we're using what we've learned, in our rising stars at those sites that are still struggling. But I want to kind of concisely describe to you the success that we have seen with this. And Rachel will go into detail about how this happened, how this success occurred. But recently, and this actually happened before after we sent in our slides. So recently, the team at GWV experienced a day from obstetric, disaster. So basically, in a very, very short period of time, they had 8 emergencies, all pretty significant, unplanned outcomes, 2 uterine ruptures in a matter of 12 hours or something like that. Very, very crazy day. And there were scheduled cases that went somewhat unplanned. There was NICU transfers, lots going on. But when you look back at that day and when you talk to the staff about that day, everyone had support of one another. There was no fear of hierarchy in those situations. There was a significant amount of crosstalk, significant amount of support of one another, shared mental model. This is where I'm going. Call me if you need me to come back. I have to go over here to this delivery. I'll be right back. Such chaos. And in that chaos, every team member was able to rise above it. And I think that's really worth discussing here on this call because it clearly depicts why this model, this TeamSTEPPS framework, this education and support creates a culture change in an organization. Because when we started 2+ years ago, if we had that day 2+ years ago, I'm not sure we would be having the same discussion, be able to speak so proudly and so excited about how the team works so well together. And the good news is all good outcomes for moms and babies ultimately, which, many of you I'm sure have an obstetric background are excited to hear that. The tools are embedded. They're used rapid fire. You walk down the hall, you see debriefs happening, and this is happening at every hospital. But really, really great work. And the shift of culture of safety has definitely changed. We definitely have seen that. So to kind of close my portion of this before I hand it off to Rachel, I do want to talk about, when the ball does drop. And a little bit of a story about before TeamSTEPPS was really embedded at one of our sites. So one of our sites that we had was somewhat reluctant to take on the challenge of debriefs. When we started debriefs there, it was every single C-section got a debrief. That was the precedence that we started with, just to be able to track what that looked like. And at that site, the delivery went somewhat chaotic, but the outcomes were fine. And no one on that team decided to meet afterwards and debrief about the cesarean delivery that occurred. Shortly thereafter, I'm getting text messages. Hey, can you come over? I have some concerns. Hey, do you think you can come and talk to this group? I'm not really sure why we intervened with a C-section when we did. So now I got put in the middle. And I remember standing there and looking at a neonatologist and an obstetrician and a nurse, a charge nurse. And I said, you guys all can have this conversation together. Why don't we just debrief now? And it really just made it very clear the importance of some of the 100-level, 200-level tools in all of this. They all knew what they wanted to ask, but they were not comfortable asking that of each other. They were not comfortable having that multidisciplinary crosstalk. And it created this shift in their thinking. Like they were blaming people that they really had no real idea what actually happened, what the thinking was of the obstetric providers. And there was so much blame going on and finger pointing. And then when we brought the whole team together, suddenly the blame went away and there was understanding. So I think, taking it in, the ball definitely dropped. They could have debriefed. They could have, created less of a dramatic situation after that delivery and come together as a team. And it caused a lot of conflict. When they finally did come together, it did prove to be successful. So I'm going to hand it off to Rachel, who will tell you a little bit about herself and the wonderful work that she's doing at Geisinger, Wyoming Valley.
Thank you, Elissa. My name is Rachel Cunniffe, and I'm the Nursing Professional Development Specialist in Obstetrics. I've been an OB nurse here at Geisinger for 10 years since I started my nursing career. I am certified in inpatient obstetrics and have been a TeamSTEPPS master trainer since 2017. Most importantly, I'm a mom and a wife, and I have 2 boys who love baseball, as you can see from the theme of our presentation here. So I want to talk a little bit about our briefs. So this was one of the first tools that GWV deployed upon our TeamSTEPPS journey. So what we found was years ago, we had a divide. So we had providers who were giving report off in a corner, and then we had nursing who was giving report nurse to nurse. There was never that interdisciplinary teamwork. So with the institution of briefs, so our unit changes shift for nurses at 7 a.m., providers change at 8 a.m. We instituted the briefs so that way we can all meet in one dedicated space, run the board for the entire unit for that time frame. So really what we wanted to look at is we wanted to anticipate our high-risk patients and recognize the additional support for the care of the moms and the babies. So we found some great catches, as our slide depicts. We were able to identify patients at risk for shoulder dystocia and talk about them as a team. So with your OB providers, with your pediatric providers, with your anesthesia care team, your high-risk nursing team, as well as the bedside nurses, how can we be ready and how can we make sure that within minutes, of a recognized shoulder dystocia, we're ready to react and respond. We also, during a brief one morning, we had a patient roll in on a stretcher via EMS that had a known placenta procreta. So this patient was supposed to deliver at our other hospital, which is GMC, which is quite a few miles away from here. So knowing that this patient was bleeding and knowing the severity of the case, we were able to, during the brief, basically maneuver all of our teams to prepare for this patient. And how could we safely transfer this patient to GMC in a timely fashion if she was stable? So we had anesthesia prepping our main OR just in case we needed to move quickly. We had additional staff come over from the OR and as well as anesthesia. The providers were on the phone initiating that transfer process while the nursing care team was in taking care of the patient. So this patient was stable for transfer, was transferred to GMC, and actually had a long C-section, I want to say like a 6 or 7 hour C-section, and needed multiple blood transfusions and a mass transfusion protocol. So we are so happy that, in that moment when we all worked together, the patient got where she needed and we had a great outcome. We were also able to identify from our briefs, was there any staffing challenges? So as we know, we all work as a team together, and OB needs to be staffed safely, so does NICU and our postpartum unit. So we're able to talk about staffing challenges and our census. We were able to pick up that there was a patient that had not been seen on the unit or evaluated by a provider yet, so the nurse was able to discuss that at the unit brief. And really a clear role designation for patient flow and timely discharge. Our vision was a well-oiled, multidisciplinary team approach, which I can 100% say has changed our unit significantly. So I think Babe Ruth couldn't say it any better. So you may have the greatest bunch of individual stars in the world, but if they don't play together, the club won't be worth a dime. So that is truly fitting of our team approach of TeamSTEPPS. So we have to make sure our teams are functioning, and they're high functioning, and we work together. So the impact of TeamSTEPPS here, we have decreased our sentinel and serious events. We have embedded the process of brief attendance as a part of daily practice. We started with measurable cases for debriefs such as C-sections. Then once we ingrained, now we debrief on every unanticipated event on the unit. Attendance is recorded at huddles and briefs for compliance, and again, that was really started to make sure we can embed the process throughout all of the teams. We have found by drilling and simulations that there were definitely opportunities to quantify our work and make sure the takeaways from simulations and learning were worked on, were fixed, and able to best work well with our teams. The future of TeamSTEPPS here, the one thing I will say is the staff sees that it's working. So if your staff can see the value and the education you're providing, the changes that we're performing, they're going to continue to do it without a question. So one of the ways that we do that here is we highlight our successes. We highlight the good things that are happening here, those great catches. We highlight them for our staff at our monthly staff meetings. So the future here is really to support the importance of our current tools, add additional tools as needed. Elissa spoke a little bit about integrating those new provider and nurses as they come in. We're going to reboot this at multiple sites because of the influx of new providers and nursing staff. We're going to dig deeper into the culture of safety and, again, provide positive feedback and transparency as things come up on the unit to all of our team members. And lastly, do some team building with TeamSTEPPS, taking personality assessments, getting to know who your teammates are so we could work better. Lastly, keeping your eye on the ball, so making sure that there is continuing education on your unit constantly. Clear communication between all team members, timely follow-up, as well as frequent pulse checks. And again, I can't stress enough how to celebrate your successes. And now I will hand it over to Dr. Conterars.
Hi, thank you, everybody. I'm really happy to be able to share our experience at the Atlantic Health System. I am the medical director for the Atlantic Health System for Women's Health. And as you can see here, we are a 5-hospital system with a children's hospital in northern New Jersey. We have 4 labor delivery units in which we deliver approximately 10,000 babies. And we consider ourselves one service line. We call ourselves One Atlantic. We have 2 NICUs, one at Morristown and one at Overlook Medical Center, and Morristown is a regional perinatal center. We have residents, and we have MFM team that are 7 folks who are system-wide and who take call at both our major centers. 2 of our other units, one is a rural center and one is more of a community center. So we really have a variety of sites. We decided to do system-wide TeamSTEPPS training in 2019. And Chris can tell you that when he and I spoke, I asked him to think a little bit out of the box and think about this, doing it a little differently. I did not have funding for champions and, for master trainers, and I asked him to think about with me ways in which we could get this integrated into the DNA of our program as having champions as opposed to master trainers, and really create a culture that was TeamSTEPPS driven. don't know if it was the right or the wrong way to do it, but we felt very strongly that this might be a way to do it a little differently than in other places. I also asked that the TeamSTEPPS training be largely on obstetrics, and we took all the labor and delivery nurses from our 4 different units, and all of them came to be trained. We also did all our labor and delivery employees, and all our providers across our system were also required to attend. These are voluntary providers as well, but we felt it was really important. Even our G1 oncologists came, and all our specialists in urogynecology and minimally invasive surgery, as well as our gynecologists. It was feeling that we had to work together as a department and really create one way of thinking. So we really moved to integrate everybody into the process. We really leaned on the principles of how we were going to lead teams, have mutual support, communicate, and situational awareness. We then took up the idea of having 2 daily briefs, and we had them twice a day, in the morning and at night. We established a clear-cut time every day, and it was different at each institution, especially if we had providers who had to be at both different sets. So our MFMers had to be at both, and how could we do that if they were at the exact same time? So we established different times that would happen on different units. We also established a clear-cut attendance group that needed to be present. The NICU, anesthesia, nursing, we brought in both the labor and delivery and the postpartum teams because we thought it was important that the folks on labor and delivery knew what was happening on postpartum, and the postpartum team should know what was happening on labor and delivery. We brought in the providers, we brought in social workers, and really invited anybody else who really wanted to attend. We then described what would happen with huddles. We brought in Category 2 huddles. We really described any other kind of huddle. And we also established what we thought was important for pre-C-section huddles. We really integrated this with anesthesia, and we came up with our own name, which is, we call it a TOAD. And that represents timing, obstetrics, anesthesia, and departmental status. So what does that mean? Tell us what kind of a section this is for timing. Tell us what's going on obstetrically with the patient. Tell us what the anesthesia needs are for the patient. And then what else is going on in the department. And it's really amazing. We keep a paper copy of this, and we go through it monthly and report out what we find. And we have caught many, many situations where things weren't just quite what we thought, and figure out, oh, the blood isn't back yet, or that the patient has something that wasn't in the H&P that was relevant. So we really put everybody together and really changed things. Then, I have to be honest, the Geisinger team came and helped us during our TeamSTEPPS training, and we were really lucky to get some really great ideas from them that we then copied. And so we put together a post-C-section huddle, a debrief, and we actually asked 3 questions. What did we do well? What could we could do to be improving, and what is one thing we should change immediately? And interestingly enough, we had one site that really incorporated this very well, and then the rest of the sites followed suit. And really what it was is the anesthesiologist spoke to the mom ahead of time and said, listen, at the end of your section, you will hear the folks talking about 3 questions. And if you have something that you want to contribute, please do, because we'd like your input. Well, I have to tell you, some of the most valuable information that we encountered came from mom. And so it was really helpful. It was not scary, which people think it might be, because we let mom know ahead of time of what we were doing, and it has really proved to be valuable. We put those 3 questions on the back of the paper that we do the toad on. We do the back side has the 3 questions, and we actually write down the things that are suggested, and we go through them, we collect them, and we really try to integrate them into what we're doing. We really then talked about how are we going to put together our expert team. And so we decided that we really needed to have common policies and common languages, and we have worked as a system to come up with policies that are same across the system. And some of them have to do with even communication of physicians to everyone else. How do we escalate? Certainly some of the basic ones, hypertension, Pitocin, postpartum hemorrhage management, early warning signs. And so it has really helped everybody to understand what the expectations are by having a common language. So what else did we do? We put together a system-wide collaborative, and what we did was this was multidisciplinary, and we have participants from all 4 sites. We have nursing, physician, midwives, people from the risk department, quality, CMOs, CNOs, coding, data analysts, and our EPIC support for our EMR. And what we did is we put different teams together to work on different groups. So we took the leadership from each hospital as the chairs and put them to run different committees. And on those committees, we integrated people from different sites. So it wasn't that one committee was made up just from one hospital. No, you might have the chair at one hospital and the nurse manager from another hospital. And what that did was really create an environment where we understand each other's issues and concerns and really created an environment for mutual support as we were trying to go with these common goals. So this is also how we measure quality, and we have a system-wide, each hospital has a system-wide dashboard, and we look at where we are in our goals related to management of hemorrhage. As far as hypertension, our goal is to make sure that we're giving the correct medication in both less than 30 and 60 minutes. We look at our NTSV goal of reducing to less than 23.9, and then we actually report out on situational awareness. We actually have monthly meetings where this has to be reported out, even as far as attendance occurred. And so we really have incorporated this as transparency of data and share amongst everyone on our monthly meetings. This has been an incredible experience related to COVID, and much of what we learned through TeamSTEPPS and our short time with it, we were able to utilize during our COVID experience. I broke this down into 3 ways that we looked at it: leadership and team support and mutual support. So when we were hit with COVID in northern New Jersey, which we got hit pretty hard very much by the middle of March, we realized we really had to move quickly. And we took this on as one service line. We had one shared mental model, and we standardized approaches across our service line. Nurses and physicians from across the service line were brought together to represent each hospital. We recognized that we were going to have to care for COVID-positive patients and COVID-negative patients on the same unit, and that presented a whole level of challenge that we really hadn't considered beforehand. We realized that we had experts among ourselves, and by putting us all together in a room, we would come up with some really great solutions. So we came up with the solutions related to how we were going to manage our labor and delivery ORs, how we were going to handle vaginal births. We decided to eliminate all elective inductions because we just didn't know what was coming ahead. We made decisions about how we were going to handle postpartum care and have rapid discharge, how we were going to handle the visitor situation, and what we were going to do about PPE, because as all of you can remember, there was no clear guidelines how to handle all of this. We decided as a group to come up with our own. Finally, we also addressed this based on nursing and physician representation related to our emergency room partners as well as our medicine teams. We recognized that patients would have different levels of being ill during COVID. There would be some who had mild illness and no laboring issues. We got together with the ER and said, okay, how about you take care of them and we'll help you, but they don't need to come to labor and delivery. On the other hand, there were mild patients who had mild illness and had laboring issues, and those should come to labor and delivery. Those who were moderate or severely ill, those didn't belong on our unit because we recognized that they were too sick for us, but we got together with medicine and the ER, and those patients would be sent to a respiratory unit, and we would go to them. So we had to put those plans in place by working together and supporting each one of our units so that we would be able to provide the best care to our patients. So reflecting on it, we're grateful that we had all of this in place. We also recognized that there were other areas that we would have to work with, and really recognized that if we needed to work together with their leadership so we could all be mutually supportive of each other. So we set up algorithms that worked. We got together with the transportation departments security, environmental services, and really work together, support each other so that we understood the constraints that each other was under so that we could get the best outcomes. We recognized that perinatal care was going to become a big issue. Very quickly, we had to flip to virtual care. And how were we going to do that? So we put together providers across voluntaries, full-time, and the clinic so that we could come up with a system that worked well for everybody. As many of you know, we had to standardize how we were going to handle this. We had to incorporate virtual care. We really had to figure out how we were going to do this and how we were going to make it standardized across our system. And we were very successful by putting together small work groups and assigning different tasks to different people. So what did we do as far as communication is concerned? We recognized that the most important thing is that we made it clear to everybody what was going on. We needed transparency and clarity. So we established a daily call. We did this 7 days a week throughout the entire COVID experience. And I think we went until probably the end of June with the daily calls where we had operational calls first with nursing, the hospitalists, and residents. And then we had provider calls. Every day there was a 30-minute call. We had providers in the hospital, providers outside of the hospitals, and office staff got on the call. We had one established number, and every day it was very clear that if you called in at 7:30, there was a call. We spent 15 minutes talking about an update as to what was going on within the state and what was going on with the hospital, and then 15 minutes where we would answer questions and really try to understand where we were as a service line. This provided us an opportunity to bring in ID experts, the NICU, anyone that really could provide us more information so that everybody could be on the same page as to what was going on. As most of you and all of you know, during COVID, everything changed very rapidly. So we tried to bring the team together so that everybody would have the same knowledge by bringing in whoever needed to come to the call. We also then created minutes at the end of every day. And by the end of business at every day, minutes went out to every single person on the service line who wanted the information. And at the beginning of COVID, we even solicited people their email accounts, even if they weren't the system-wide email accounts, because we wanted to make sure we had clear lines of communication so everybody understood what was going on. And we kept a large book of what were all the changes that were going on because the changes were happening so rapidly. Interestingly enough, what happened with communication is everybody then started to canvass social media and their friends throughout the country and the world as to what we could learn from it. And they shared with everybody else on the line what we were learning. We were desperate for information, and people started using whatever forms of information was out there. And it was really pretty amazing how much we depended on that as to what we needed to do next. Finally, the third TeamSTEPP rule or tool that we used had to do with situational awareness. Besides our daily briefs, what we did was we established clear phone numbers that could be used at any time to huddle or to brief. And we asked everyone to get on the call. And so if we needed to huddle or we had a patient on the board that the provider was not there, we would text them and say, please join the brief or please join the huddle because we want to talk about your patient. And that way we had a clear understanding. So they understood what was happening on labor and delivery, even if they weren't in the hospital, and we understood what they were thinking, even if they weren't in the hospital. We used technology to make sure we had clear lines of communication and we could be situationally aware together. Every time we had a COVID-positive patient, or what we at that time called a PUI, we really got everybody on the call. It didn't matter if it was 2 o'clock in the morning or 2 o'clock in the afternoon. We had these standardized huddle phone numbers, and so we didn't have to have everybody in the hospital, but we had a way of reaching everybody immediately. And we made sure infection prevention, MFM, peds, the providers, nursing, everybody was on the call so we could have situational awareness of exactly what was going on so everybody was on the same page. So what were some of the key points that we learned? We learned that it was really critical that we were flexible, that we were really adaptable, that we thought outside the box, that we really had one common language, one common approach, and that we were really open to transparency. We really created an environment for teamwork, communication. It was really important to have leadership at all different levels. People took on jobs that I've never seen people take on before, and that we had a way of documenting what we were doing so that when we needed a reference, we knew exactly where it was. What were some of our challenges? I can say the first 10 were fear. I think everybody feared what was going on during this pandemic. The CDC recommendations were constantly changing, and change was part of where we were living all the time. There was no standard approach. We had no history of this disease. We didn't even know what kind of PPE to recommend to people. We had hospitals that had different kinds of resources and different kinds of demands based on the amount of COVID-positive patients that were coming through our doors. And we really, at that time, did not know what was going to happen to a mom or to her baby. At that time, we were separating moms and babies. The anxiety that that created was unbelievable, and we had to continue through that. We had to make sure that patients had the most positive experience that we could give them, at the same time trying to give the safest place possible. For all of you out there who have been through it, I know I'm speaking to everybody knows what this was about. So where are we with next steps and what to do with our TeamSTEPPS? We know that TeamSTEPPS has helped us to create value for our obstetrical line. It is really important that we continue to value our patient outcomes and our patient experiences. TeamSTEPPS has helped us as far as our patient outcomes because we have tools by which we manage our major dashboard indicators, which have to do with many that ACOG has said it as important: NTSV, hemorrhage, management of hypertension. Those have been critical as our main 3 pillars that we look at. We know if we manage those and have fewer complications, we are giving great outcomes and improving, obviously lowering the cost of care. So we are working very hard to how do we get sustainability and teamwork at the same place that we were during this amazing time. How do we continue to have the engagement of voluntaries who really stepped up and stepped forward during this time, but are now less engaged and tired? How do we do virtual simulations because we can't all be in the same place anymore? And where is the role for telehealth? So those are some of the things that we're using. I'm happy to answer any questions anybody has. I'm really grateful for the opportunity to share what we did. And I'm going to turn this over to Chris now. So, Chris, it's all yours for question and answers.
Thank you, Dr. Conterars. I thank you all, Elissa, Rachel, all 3 of you. This is what I love about the TeamSTEPPS community so much is that we have a situation here where, Geisinger stepped forward and learned all about TeamSTEPPS, and then we're willing to go and share with Atlantic Health System, and it's wonderful to see the collaboration. So thank you all for joining. So questions in our remaining minutes here. Definitely, and this goes to both health systems, a lot of questions around the idea of bringing people together in a multidisciplinary way, whether it be in huddles or during debriefs. How do you go about doing that? People seem to be having very specific challenges that we hear a lot about. You might have the OB physicians in one area, the nurses in another area, anesthesia somewhere else. And so, I think it's important definitely to have leadership push for that. But how do we go about doing that?
So, Chris, Rachel, and I were just chatting about this. I think while we want to create a very clear perspective that there should be no hierarchy in these discussions, what has really helped us is that when leaders, whether they be formal or informal leaders, are kind of planted in those areas, to be able to take the lead in that situation. So as an example, today we heard a nurse concerned about something that she felt like she wasn't heard. So we just kind of stepped in and brought the team together and modeled the behavior that we want to see. And, that way, next time, that nurse might be a little bit more inclined to do that herself, or that provider may be a little bit more inclined to do that themselves. And I think that really has helped us. Leadership kind of pushing it in a way, but in a way that leads by example. Bringing all those teams together. Sorry, go ahead.
I think that training during the time of TeamSTEPPS, it's really helpful to break down the hierarchy at the time of the training. I think if you can mix your groups at the time of training, it's also very helpful, because I think it's really how you view teamwork and cooperation and collaboration. And I think it really helps from the very beginning to establish that hierarchy isn't always the best way to go.
For sure, yeah. I remember doing that in your trainings. You were very good at bringing people together and sitting them with others at tables that they maybe wouldn't normally sit with. Question, and I think especially with Atlantic, and I'm not sure about Geisinger, but with Atlantic Health System, you definitely have some physicians that are not employed by the hospital, right? So how do you go about getting them on board with this?
So we have quite a few voluntaries. We actually have very small number of full-time employees. And I think what has really been critical here is the value that TeamSTEPPS brings. And so opening up lines of communication and engaging them in we're having a brief about your patient. We understand you're in the office. Can you get on the line and to help us to understand so that we're all together? I think that has been a really positive approach, using technology to help us all to come together, even when it's hard to come together. So I think when we do those kind of things, I think it really means a great deal to the volunteers to be included, and that helps to move the bridge of getting together as a team.
Have either or any of the three of you seen TeamSTEPPS been used to reduce conflict? So there were a lot of comments in here about, the phenomena of nurses eating their young, or other things, along the lines of, along the power gradients or something along that.
So, yes, this is Elissa and Rachel. I mean, we definitely have seen it used in that way. I think a debrief sort of just lends itself to remove the blame, because you're just self-reflecting. So I definitely see that the tools themselves sort of lend themselves to address conflict. I think about, where is the conflict coming from? And how, which tool will help to kind of address the root of that, depending on what it is. When we started, Chris, we had a lot of conflict over fetal monitoring strips. So it was, provider say over nursing say, and the implementation of Category 2 huddles has helped bridge that. So, provider and nurse are on the same level. There's no hierarchy. There's no conflict anymore, because the nurses and the providers both need to, meet with the team, describe what they're seeing, talk about the strip, and they're doing it together instead of separately.
Thank you. That's great. All right. So we are close to the top of the hour. So I just wanted to remind everybody that there will be a recording of this available. We also have an evaluation that will be coming to you, and we look at those. We really do use them to try to do better and to make improvements. If you're interested in CE credit, make sure that you follow the instructions that are in the file pod that you could download. The basic instructions are on the screen right now. Other than that, I'd like to thank all three of our presenters for their great presentation today. I'd like to thank Enjoy Health again for sponsoring this webinar, and I hope everybody has a wonderful rest of their day, and we'll see you all in November. Thanks.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.